In recent years, a silent crisis has been unfolding on both sides of the border. Colorectal cancer, once considered a disease of older age, is now striking younger adults with alarming speed. In Canada, people born after 1980 are 2 to 2.5 times more likely to be diagnosed with colorectal cancer before age 50 than previous generations. Incidence among those under 50 has risen steadily, with the sharpest increases in adults in their 30s and 40s. Young onset gastrointestinal cancers are among the fastest rising cancers in this age group. And in the US, colorectal cancer has become the leading cause of cancer death for Americans under 50. This isn't just numbers, it's changing young lives, careers, and families across North America. But Memorial Sloan-Kettering Cancer Center is home to the world's first dedicated center for young onset colorectal and gastrointestinal cancers. My guest today is gastroenterologist Dr. Robin-Mendelsohn, co-director of the center. From groundbreaking research to care that respects fertility, careers, and quality of life, we will discuss why MSK is helping lead the fight against young onset GI cancers. Thank you so much for joining me today. This is obviously something of great concern and widespread in North America. So let's just jump right into it. Why did you decide to enter into this area of medicine? Was there any personal family interest?
So there was no personal family interest. And actually, when I started medical school, I thought I was going to be a pediatrician, but
Oh.
left that quickly. But, in general, GI is the best specialty, in my opinion, because you really everything from screening colonoscopy to end of life palliative
Mm.
procedures. You get to see patients, you get to do procedures, you treat everything from esophagus, stomach, colon. So you really get to see a wide range of diseases and people.
Now, as a gastroenterologist, which I stumbled my way through with over 20 years of experience, what led you to specialize in managing GI issues in cancer patients, particularly those with hereditary syndromes like Lynch syndrome? And can you please explain what Lynch syndrome is for our viewers?
Absolutely. So, Lynch syndrome is the most common cause of hereditary colon cancer. It accounts for
Okay.
about 4 to 5% of all colon cancers. So, many, including us at Memorial Sloan Kettering, advocate for universal screening, meaning that anybody that comes in with colorectal cancer, if they're 18 or 118, we screen them for Lynch because that has
Mm,
implications for how you're treated and how your family is treated.
okay.
But the reason why I particularly enjoy taking care of cancer patients is that it's such a special cohort.
Mm.
And as a GI, I'm able to really help these patients. So, what I'm able to do is help them with symptoms either from their cancer or from their cancer treatment. A lot of us take for granted that we can eat and go to the
Yeah.
bathroom. And when you lose the ability to do these things, as a GI, I'm able to help with that. And that provides so much extra happiness in my job.
Now, you co direct the Young Onset Center with Dr. Surchek. Did I say her name properly?
Perfect.
Surchek?
Perfect.
How do your backgrounds complement each other in caring for younger patients and investigating why these cancers are rising in people under 50? We have 1 minute. Mhm.
Yep. So we actually train together. So we're colleagues and friends. And we started this center together and we work so well together because she's a GI oncologist. So she takes care of the cancer side of things. And then I'm able to take care of the symptoms and the screening and the follow-up, and really be able to provide comprehensive care to these patients.
Wow, that's wonderful. You're a power team then. All right. Okay, well, stay with us. When we come back, we will dive into the silent surge right after this. Welcome back. I'm speaking today with Dr. Robin-Mendelsohn, and we're talking about GI cancers, in particular, ones that happen under the age of 50. Now, what inspired MSK to create the first clinic dedicated specifically to young onset GI cancers?
Yeah, so unfortunately, as you described, we've been seeing this increase in these younger patients. And what we found was that the cancers are similar. So we know how to take care of their cancers, but their needs are so much different.
Mm,
The needs of a 20, 30-year-old compared to a 60 or 70-year-old. And what we found was that the resources they needed were different. Both from a what we could offer, but also from a support standpoint. People in their 60s and 70s, a lot of them know people that have cancer, have colleagues with cancer,
yeah.
whereas people in their 20s and 30s felt very alone.
Mm.
So, our idea was really to create a comprehensive center that we could take care of these patients through from diagnosis and then hopefully through survivorship. And of course, the other side is the research side of things to really figure out why this is happening and what we can do to intervene.
Yeah, so colorectal cancer was once considered a disease of older age, as we've been saying. So, why are we now seeing rates double in adults under 50 since the mid 1990s?
So the short answer is we really, really don't know,
Mm.
and
Okay.
it's troubling.
Yeah, yeah.
We're working at it and trying to figure it out. And I think what we're discovering is that it's probably not one thing that we can attribute
Mm,
it to. When, like I said, when we look at the cancers, they appear similar, so we treat them similarly. Um, but when we look at the traditional risk factors of colon cancer, that doesn't really fit the bill for these patients. So we
okay.
think it's probably some sort of exposure, some sort of underlying genetics that predisposes you to react to this exposure. But what exactly it is, we don't know yet.
Okay. Well, recent data show colorectal cancer has become the leading cause of cancer death in people under 50 in some groups. Can you explain what the latest stats tell us about this trend? You talked a little bit about that. Is there anything else specific?
Yeah, so we've been seeing this increase in younger people. It's increasing about 2 to 3% per year since the
Wow.
1990s. The biggest increase is actually whites with rectal cancer. That seems to
Okay.
account for the biggest increase in the group in the United States. Nonetheless, unfortunately, we're still seeing disparities with Blacks having overall poorer survival. And when we
Mm,
look at it, we think this is likely more due to access to care
okay.
as opposed to something biological. So, as part of our center, one of our main goals is to take care of these patients, but also to get the word out that this
Yeah.
is happening. You talk to these patients and you even talk to providers, and they think, oh, you're too young to have cancer, or you have,
Yeah.
rectal bleeding, it has to be hemorrhoids. So, one of our goals is really to get the word out that this is happening and really try to make sure that everybody is given access to good care.
Absolutely. So, what about early onset cancers of the pancreas or the esophagus or stomach or appendix? They've surged too, 15% in the last decade. What patterns are you seeing among these GI cancers as well?
So, very similar. We're seeing this increase. We don't know why. We're treating them the same as we treat our average onset cancers. And that is
Mm,
actually why, when we started the center in 2018, and we
okay.
started it as colorectal cancer. And then we expanded to all GI cancers in 2021 because we saw this increase and we wanted to give everybody the resources and really
Right.
try to figure it out. But again, it seems to be something beyond genetics. Most of these are sporadic. There's no family history, there's no genetics. Only about 10 to 20% of these patients have a genetic mutation or a familial disposition. So it's something that we're being exposed to, but what that is, we still don't know.
Now, I think we'll move on because I really want to dive into your actual trials and your treatments. So stay with us, everyone, and we'll get into the nitty gritty of that right after this. Getting the news of cancer at any age is difficult, but especially for the young. MSK's immune treatment trials bring hope for recovery. Okay, so let's talk about that. As co director of Young Onset Center, how are you integrating immunotherapy trials into care for younger patients, especially those with hereditary risks like Lynch syndrome, as we mentioned earlier?
Yep. So immunotherapy has been a part of our center. And what it treats is in general, so Lynch syndrome, like we talked about, is the
Mhm.
most common cause of hereditary colorectal cancer. And their tumors are different than sporadic tumors. And what their tumors have are certain markers that we call mismatch repair mutation. And if you have a mismatch repair mutation, when we look at tumors, there are missing mismatch repair. So we call it a mismatch repair deficiency.
Okay.
And if you have a tumor, whether you have Lynch syndrome or you have young onset cancer without a hereditary mutation, but your tumor has a deficiency in mismatch repair, then immunotherapy has been shown to be really effective. And we do, that is considered routine treatment for those with advanced diseases.
Now, I did read up in Canada. It's this particular dostarlimab. Is that how you say the name of the
You
drug?
got it. You
Oh
got it.
wow!
Yep.
Now it's not used as a standalone in Canada yet, and it is in trials in like Prince Margaret Cancer Center and in Ottawa and Halifax and Edmonton. So they're working on it, but you're spearheading it there. What other novel immune or targeted agents are you exploring in trials to boost responses in colorectal and GI cancers?
Yep. So now we're researching in trials using combination immunotherapy and chemotherapy.
Okay.
So that we're investigating that in trials now. And we're even trying to look in tumors that don't have mismatch repair deficiency. So in those where those proteins are still there, what we call retained, in clinical trials, we're looking to see if combination immunotherapy or immunotherapy and chemotherapy can be helpful.
So, for a person facing a GI cancer diagnosis today, how hopeful should they be about immunotherapy changing their treatment path and quality of life?
Yeah, so I think, it's something that's very hopeful, and it has been shown to be quite effective in certain scenarios. And we're hoping that we can bring this to other scenarios as well. And it really changes the trajectory and the survival.
Now, how far along on the in the trials are you? Is there How long do you think it'll be
So
before
there's
this might
many
become
trials.
standard?
Yeah. Yeah, so there are many trials going on at different stages, and we're hoping to get answers as soon as we can.
Sounds great. All right. When we come back, we will look at ways young people can reduce their own risk of getting GI cancers. Stay with us. Benjamin Franklin once said that an ounce of prevention is worth a pound of cure. Dr. Mendelsohn, screening guidelines for colorectal cancer now start at age 45 instead of 50. Should some people start even earlier? And who qualifies?
Yep. So it is the most important thing is to really know your family history. And some families don't like to talk about these things, but it is so,
Mm,
so important because there's really four questions that we ask to see if you start before the age of 45. And that's if you have had any colon polyps or colon cancer,
okay.
if anyone in your family, and we usually consider it first degree relatives, so parents, siblings, children, have had colon cancer or colon polyps, if you have inflammatory bowel disease, or if you have a history of radiation to the abdomen or
Mm,
pelvis. So, really, most of the other ones or you're being followed, but really knowing your
mm,
family history. And then we start earlier. For family history, we recommend starting at 40 or 10 years younger than the youngest person in your family was diagnosed. So, if
mm.
anyone was 50 or over, you start at 40. If someone was 45, you're going to start at 35.
Okay. So, what lifestyle changes have the strongest evidence for lowering risk of colorectal and other GI cancers like diet, exercise, weight, alcohol, smoking, etc.?
Yep. So, I think many of these appear obvious. We say don't smoke, don't drink alcohol, maintain a normal body mass index. Colorectal cancer and colon polyps have been associated with obesity. They've been associated with diets that are high in red meats and processed meats. So we recommend avoiding processed meats, red meats in moderation. It's eating fruits and vegetables are protective. So we recommend increasing fruits and vegetables, and exercise is protective. So we recommend exercising. So all of these things are healthy for you overall. So it does protect against colon cancer or colon polyps. That doesn't mean that you won't get colon cancer or colon polyps. So the
Mm.
idea is that following these guidelines will still keep you healthy so that if you do get them and you have to undergo treatment, you'll be in the healthiest state that you can be.
So, for those who hate to eat their veggies and fruits, why, can maybe explain to them why it's so protected for them to eat more of that and less of the red meat?
Yeah, so it's been shown to decrease your risk of colon polyps and colorectal cancer, and of
Mm.
course, it's also been shown to decrease your risk of heart attack and stroke and all of these things. So, we it really helps you overall for your health.
Right. For those with Lynch syndrome or other hereditary risks, what intensive surveillance or preventive options like aspirin or poly how do you say that? Polylactic surgery? Why should they discuss this with their
Prophylactic.
doctor?
Yeah, so the for Lynch syndrome, the one thing that's really been shown to be protective is to get your colonoscopies.
Okay.
And so we do recommend starting between the ages of 20 and 25, or as soon as you're diagnosed. And we usually recommend yearly colonoscopies, and that has
Mm.
been shown to decrease the risk of developing colon cancer over time.
Mm.
There was one study that did show that very high doses of aspirin may be protective. So,
Okay.
to put it in context, a baby aspirin is 81 milligrams.
Mhm.
This was done with 600 milligrams.
Okay.
So, very high doses. And the first study didn't show an impact. The second study did show an impact to decrease your risk of developing colorectal cancer. So, I don't routinely recommend that people take these high doses of aspirin. We don't have good data right now to show that baby aspirin is protective, but some people do choose based on that data to take a baby aspirin. But we do have some ongoing trials now trying to figure out what perhaps a lower dose of aspirin may be equally effective.
Okay. So if someone in their 20s or 30s notices persistent symptoms like blood in the stool, abdominal pain, or unexplained weight loss, what should their first steps be to protect themselves? You mentioned going and getting a colonoscopy. Would that be the first thing, or what would you
So we
suggest?
would recommend to first get evaluated
Okay.
by your usually a primary care physician is the first person, and they'll refer for the next steps. It does, unfortunately, the data show that people usually have to see multiple doctors before they do get diagnosed with colorectal
Mm,
cancer. I do think it's important to note that most people with these symptoms will not have colorectal cancer. So if you have
right.
bleeding, persistent bleeding, you should definitely get checked out, but that doesn't mean you will have cancer. But the colorectal cancer, when it's found early, is beatable, treatable. So the earlier it can be found, the better. So any
Mhm.
symptoms that are persistent, definitely see your doctor and advocate for yourself. We are
Mm.
trying to get the word out again to both patients and providers. Younger people can get cancer and need to be evaluated.
I think that's a very important point that we can finish up with, that advocate for yourself to make sure that you are looking out for yourself and ask the right questions and go to your primary care provider and get yourself checked out. So I appreciate you saying that. And it's exciting what you are accomplishing at the center. And hopefully it won't be long before it's an option across not just the US and gets into Canada and around the world. And one more tool be able to come against this. So thank you so much for your time today and joining us on the show on A Healthy Dose.
Thank you for having me and for spreading the word.
A cancer diagnosis at a young age doesn't define your story. Your courage, resilience, and determination do. To every young patient, survivor, and family watching, you are not alone. With better understanding, earlier detection, and more personalized care, so keep listening to your body, keep asking questions, keep fighting with everything you have. Until next time, I'm Julie Stautland for A Healthy Dose.